Thank you very much for the invitation and to Professor Eliannis for this kind invitation. And I would like to speak about this very important problem. It's a recommendation for exercise in patients with coronary artery disease. And recently, now some important international journal published article regarding the problem of exercise is medicine, and physicians need to prescribe it. Therefore, there is a new medical culture to promote, aim to promote the physical activity in secondary and also primary prevention of coronary artery disease. Because there is this slide is very impressive, because the problem with exercise and heart, and there is a balance between the benefits and risk of exercise on the heart. And from the benefit in primary and secondary prevention of cardiovascular disease, and therefore the chronic adaptation of these benefits. And the other side, there are the risks, in particular in subjects with silent and asymptomatic cardiovascular disease, and therefore in the acute adjustment. Therefore, the doctors, a good doctor, should balance these two points between benefit and risk. The World Heart Organization showed that physical inactivity is one of the leading risk factor causes of sudden death in the different countries, in particular in the subject and in the countries with the high income. The slide shows the mortality projection from 2004 to 2030. This slide is also belong to the World Health Organization. And in yellow, you have the disease with a favorable impact of exercise. You can see that the projection from 2004 to 2030, for instance, for the coronary artery disease, is that there is no variation. Maybe the mortality can increase during this year if we don't apply any protocol, any prevention of primary or secondary prevention. This is a very important point. Also for other diseases like diabetes or hypertension, you can see there is an increase of ranking of these pathologies. And also for cancer disease, for instance, the most important study on cancer disease regarding the colon and rectum cancer or breast cancer. There is also, sorry for the Italian, but I resume in English. Also for the children, there is a big impact of sedentarism in this. You see in the south of Italy, there is an increase of the obesity in the child. Therefore, it's a very important point to start in prevention in the childhood and to fight the obesity in this population. There is also an impact of economic side regarding the sedentarism, and probably the increasing the exercise in the population, we can have an advantage in the benefit of the population. Also from economic point of view. Therefore, now we have to think about this new model of exercise prevention in the patient and also in the normal individuals. This slide shows that the difference between the prescription of physical activity and the other side is the prescription of sport, because both are very important. Because physical activity is considered a repeated, planned, and structured body movements performed to maintain or improve physical fitness. Therefore, it has a preventive value. But we cannot forget the importance of sport, which is considered a physical activity that involves individual or collective competitive situations that are structured and subjected to rules. Therefore, the importance of sports as a recreational value, and to adapt this prescription in each subject. Therefore, the concept of exercise is medicine, and there we can see that there are a lot of pathologies we could benefit in sport. Now, in this speech, I speak about the importance of this prescription in heart disease, but you can see also lung disease, hypertension, diabetes, obesity, cancer, and osteoporosis. There is therefore a very important spread prescription, spread indication of this exercise. These slides show how we can prescribe exercise in the subject, in the modality, for improve the functional evaluation of a patient with heart disease. We have to consider very important point, not only the cardiorespiratory fitness, the improvement in the aerobic capacity, but also other important point. We have to focus on that. For instance, the muscular strength is very important to improve. Also, for the problem in the elder population with the risk of sarcopenia. Therefore, it's very important to improve also the muscular strength and prescribe that. And also the proprioceptive capacity and the flexibility. Therefore, now the possibility of prescribed exercise is beyond the aerobic capacity. There is a lot of reference and literature about that. This study is very important because it showed that for reducing cardiovascular mortality or reducing the whole cause of mortality in primary prevention, it's enough to improve a little bit the cardiovascular this exercise prescription. You can see the time is not so much, less than an hour in week, and also the distance is less than 6 kilometers. This is enough to reduce to improve the outcome of these patients. And also you can see that there is maybe an increase of risk if we can increase too much the exercise, and we increase the risk also, as I said before with the first slides, with the balance between risk and the benefit of the exercise. Therefore, the exercise good is not too much. This slide is very important because it's related to the intensity of aerobic exercise, and it's very well known that the optimal intensity range is between the 70 and the 85% of maximum heart rate, or a little bit less regarding the VO2 max. This is the intensity, optimal intensity of exercise in each session of cardiac rehabilitation. And you can see that if we remain in this range between 70 and 85, we have a good in green gain in fitness, a good adaptation, a good chronic adaptation, and we can reduce the risk of cardiovascular complication if we remain, if our patient remains below the 85% of maximum heart rate. Therefore, it is very important because if we have to prescribe exercise in subject with more competitive level, they are usually in this point of the slide, where is the major risk for the heart. Therefore, it's better to remain in this range. And also for the influence of frequency, like a session per week of exercise prescription in the patient, is better to remain about 3 times a week, 3-4 times a week. In this way, we can have a good adaptation, but we can reduce the risk of not cardiovascular, but the orthopedic complication that could occur in this patient if we have too much session per week of exercise. And also, the slides approach the other part of exercise prescription, and the influence of duration of the session. Probably the best time is between 20 and 30 minutes per session. And you can see that the gain in fitness in green is good, but we can control also in this case the risk of orthopedic complication. We have an example also of the calorie expenditure of some kind of exercise prescription. I show you the base regarding the working. If you consider a man of 82 kilos who walk at about 5 kilometers, 4.5 kilometers per hour, the calorie expenditure is 4.8 calories per minute. Therefore, in 1 hour, we can have 250, 260 calories per minute. Therefore, we can also organize a nutrition approach of this patient. If we consider also the caloric expenditure of the different kind of exercise. In this slide, we have also an example of calorie expenditure of walking. It is very popular, very easy to prescribe to the patients. Recently, in 2021, in last year, we have two important guidelines published from the European Society of Cardiology, and one of the cardiovascular disease prevention, and the other one is regarding sports cardiology. And both of them approach the problem of exercise prescription in normal subjects and also in the cardiac patients. Therefore, I strongly suggest you to read these two important contributes from European Society of Cardiology. This is a slide will show the different cardiovascular risk in the different countries in the Europe, and the Greece is very similar to Italy, and hopefully we have also a moderate risk for cardiovascular disease with respect to the Eastern countries. This guideline suggests this recommendation for physical activity in normal subject, about 150 minutes a week of moderate intensity, or a maximum 300 minutes per week of aerobic physical activity. The indication is very strong, class 1A, but also they suggest to recommend to reduce the sedentary time, to engage at least light activity throughout the day to reduce all-cause and cardiovascular mortality and morbidity. But also, another very important point I talked before, performing resistance exercise in addition to aerobic activity is recommended on 2 or more days per week to reduce all cause of mortality, and in particular also the problem related to the weakness of the muscular strength, very common in the elderly patient with the sarcopenia. Also, for at the population level, the approach strongly suggests the promotion of physical exercise implemented by physicians in the same way as drug prescription, and should also be promoted by other healthcare professionals, such as physiotherapists or exercise physiologists, trainers, nurses, nutritionists, and so on. Therefore, also the involvement of other allied professionals is very important and fundamental to prescribe exercise in the large part of the population. These other guidelines are very important on sports cardiology and exercise in patients with cardiovascular disease, and also these guidelines approach the problem of competitive activity in subject with cardiovascular problem. And in this slide, it's very funny. you can see that there is a lot of problem in this population: heart failure, cardiomyopathy, arrhythmia, high cardiovascular risk factor with the use of score for the calculation of the risk factor, but also the disability. And very important, sharing this decision with other subjects, not only physician, with a goal to improve this exercise prescription in the measure as possible to the subject in the safe way. And this is a table from these guidelines. You can find it in the literature, but however you can see that they divide the intensity: light, moderate, and vigorous. As I said before, in relation to the MET with the equivalent metabolic equivalent. Therefore, there is a lower than 3 is light, from 3 to 6 is moderate, and more than 6 METs is vigorous. Or we can also use very easy board scale score, or also the percentage of heart rate. This is very, very important to have some suggestion, assign guidelines for this prescription. These are the different indices of exercise intensity. Therefore, we can also follow this recommended exercise intensity. Obviously, the best way to approach is to do a cardiopulmonary test, in which we can measure the VO2 max, which is the best expression of aerobic capacity, in particular in the patient with cardiovascular problem, and therefore divided in low intensity light exercise, or moderate intensity exercise, or high or very high intense exercise, or in relation to the percentage of VO2 max. But it's the same also for the heart rate, maximum heart rate, or for the reserve heart rate, or also with the Borg scale. Obviously, we have, when we prescribe the low or moderate intensity exercise, usually we are in the aerobic training zone, and if we increase the level, change, there is a mixed prescription, mixed different, also with a lactate and an aerobic threshold. Also, these guidelines suggest the same recommendation for exercise in sport, with the 150 minutes per week of moderate intensity, or with the suggestion to improve, if possible, to 300-minute weeks of moderate intensity. And also, they suggest a regular assessment of this patient, also for have a good control of this subject during over the time. For the subject with more than 35 years old, there is a major attention to the cardiac screening. Therefore, the importance of the S score, and also the suggestion to include the maximal exercise testing as prevention, to consider to prognosis purposes in sedentary people, individuals with high or very high cardiovascular risk. Therefore, we can divide the subject with low risk and high risk with a different score, less than 5% or more than 5%. If the risk is very low, we have no further investigation to prescribe exercise. If we have high risk individuals, maybe it's better to perform a maximum exercise, or in some cases the risk is very high, suggest the functional imaging test, or in some cases also the PCTA. Okay. How many minutes I have? 30 minutes? I don't remember. However, there is some recommendation for exercise in individuals with coronary artery disease, and in particular with the subject with long-standing chronic coronary syndrome. Also in this case, they suggest that the competitive sport is not recommended in individuals at high risk of exercise-induced adverse event. And also the other problem is the recommendation for return to exercise after acute coronary syndrome. And they suggest a period of cardiac rehabilitation for this subject with coronary artery disease to reduce cardiac mortality and rehospitalization. In the last minutes, I would like to show you a project that we performed in the last year regarding the subject with implantable devices. And it is a very selected population of patients. And in this project, we evaluated patient with different kind of pathology and with pacemaker or ICD to have the influence of exercise in this particular frailty population. In phase 1, we have a patient selection with physical examination and resting ECG, and the initial test with cardiopulmonary test, strength test, and flexibility test. There's the aerobic capacity with the cardiopulmonary test, and we can have more information regarding the peak power, the maximum heart rate, the V2 max, and also the presence of ECG abnormalities. The strength test is very important with the Biffi formula, and usually we evaluate the lower limbs, the quadriceps, or the upper limbs with this Biffi formula, and this is very important for this patient. And also the flexibility test with the theta reach test, lateral flexion, or backstretch test. The phase 2 is represented by the training session. Usually we perform the 16 session of about 90 minutes twice a week, plus one home training session, and we can follow this recommendation I showed before. Also, aerobic strength and both stretching also. And in the phase 3, we have the final test with the repetition of the same test we did before at the starting of this rehabilitation program. And you can see that the results in anthropometric there is no significant variation regarding the anthropometric parameters. Very important, there is the increase of the VO2 max and also the workload after the period. Therefore, there is a significant improvement of VO2 max and also for the power in watt. Also, for the strength test, we show a significant increase of strength in this patient with the checking this test before and after rehabilitation. And also, very important point, also this one is regarding the flexibility, in particular in the back stretch, there is a very important increase. Therefore, in conclusion, now we have to consider that the physical activity should be considered as a drugs, and in particular in secondary prevention, but not only in secondary prevention, also in primary prevention, as the guidelines suggest us, and must be spread to all levels and involve all the allied professionals necessary to achieve the purpose: physicians, physiotherapists, nurses, and trainers. Exercise prescription has to be implemented both in primary and secondary prevention. And the major scientific societies now help us because they publish recent guidelines on exercise prescription, even in individuals with cardiovascular abnormalities, both in cardiovascular prevention and sports cardiology. Therefore, it's essential to follow these guidelines in order to enhance the benefit of physical exercise and at the same time reduce its risk. Thank you very much for your attention. I'm open for the question if you like.
Thank you very much, Professor Biffi, for your